Okay. So we're going to talk about fetal alcohol syndrome first, and then move on to some of the others, other types of drug abuse. These are just some of the things that you'll see out there. This is more like a billboard kind of thing that you would see. 40,000 babies had their first drink before they were born. So you see some of this in, you know, on billboards and in advertisements and magazines and things like that, some sort of general ideas to just to kind of let people, you know, remind people that whatever you drink, baby drinks too, right? So that's the scary thing about it, is that we know that who are the main people who get pregnant? I mean, young people, right? Teenagers and young people. And who are the main people who drink? Teenagers and young people. So therefore, a lot of times this happens to people who don't know they're pregnant. You know, they're drinking, but they didn't know they were pregnant. So that's the scary part about the whole thing, and why they want to educate. In that if you think you know, are pregnant or might become pregnant, then you need to be very, very careful about your alcoholic consumption because of these things. Now, there's a difference between the syndrome and the fetal alcohol effects. Just like everything else, there's a lot of different levels, and they call it fetal alcohol spectrum disorder. In other words, spectrum lets you know there's a whole wide array of levels of complications, right? So the syndrome is what we're talking about, but it's not going to be the main one that happens. Not as many children have the syndrome as they do the spectrum disorder. But the March of Dimes says 1,000 to 6,000 babies born in the U.S. each year with fetal alcohol syndrome. As many as 40,000 in the U.S. That's a lot if you have the actual syndrome, because it's not good at all. One of the most common known causes of mental retardation, and actually I've read that it's the only cause that's completely preventable. You know, it's preventable in the fact that if you don't drink, it won't happen. But at the same time, like I said, a lot of people don't mean for it to happen. Okay, and then 1 in 100 babies have fetal alcohol syndrome, nearly the same rate as autism. And we just don't know about it usually. Once you know what you're looking for, you'll start noticing kids that you wonder if that's what's wrong with them. Because if you just haven't ever looked at what they look like and how to identify them, then you might never know that this mother ever drank, or you know that that's an issue. More prevalent than any of these other things on here combined. Alcohol use during pregnancy is the leading preventable cause of birth defects, developmental disabilities, and learning disabilities. Don't you wonder how many kids are out there that have learning disabilities that this is what caused it? We just never knew. Because it's not like when a child has issues, you don't ever really know what caused it, because there's lots of things that could have caused it. So you don't always know which part of their development was the problem. How much is too much? Basically, you hear 1 glass of wine a day or whatever, it changes over time. But the research is pretty clear that there's no real safe level of drinking. You just don't know what that level is. So there's no proof that any amount is safe. The pattern of drinking that place babies at the greatest risk are binge drinking or 7 or more drinks per week. That's just 1 a day, y'all. So that's pretty scary. But binge drinking would be the thing we worry about, especially with teenagers and people who were in a party lifestyle and just didn't know they were pregnant. But it can occur in babies of women who drink less than that. And again, just the different billboards and stuff that will let people remember that whatever you're drinking, your baby's drinking too. And a developing baby can't process alcohol. Developing babies lack the ability to process alcohol with their liver, which is not fully formed, and they absorb all of the alcohol and have the same blood alcohol content as the mother. So think about that. Especially if mom's, terribly intoxicated. Your baby's terribly intoxicated too, even if it's a fetus. It's a real hard thing to talk about with people because nobody thinks it's going to be them, not going to happen to them, because they're not planning to get pregnant. Of all the substances of abuse, including cocaine, heroin, and marijuana, alcohol produces by far the most serious neurobehavioral effects in the fetus. So worse than cocaine, worse than heroin. That's kind of hard to fathom, isn't it? But it really is true. First trimester affects all cell membranes and alters organization of tissues. Throughout pregnancy, interferes with metabolism of carbohydrates, lipids, proteins, retards cell growth and division, and affects the central nervous system most during the third trimester, during the time of rapid and complex brain growth. And hopefully by the third trimester, people do know they're pregnant. And if they're drinking then they're drinking on purpose, knowing they're pregnant. And that does happen. Okay, so these are some of the central nervous system issues that we see, and that microcephaly is big, pretty classic for it. It's terrible things. This is again autopsy of a normal baby versus this baby has fetal alcohol syndrome. It's just that much effect on the brain and the size of the brain growth. This is how we started to identify it in the beginning when it first started, they realized there was a syndrome, that they started noticing that these babies had a similar look about them, and there are lots of very similar things. And the degree of severity of the facial features correlates with the degree of alcohol syndrome and how much alcohol exposure they had. Short palpebral fissures is these things around the eyes. You see what I mean? I don't know how to describe them, but this roundness right here, that tight skin. Indistinct philtrum, that means the ridges above your lip. I mean, some people just don't have that, but most people do. That's one of the things we look for. Thinned upper lip. Almost no upper lip on some of these kids, and you'll see when I show you a bunch of more pictures. Short upturned nose. They have a flat mid-face. This right here is real flat, and that's especially if it's not a family feature. Small lower jaw, and then underdeveloped mandible. That picture doesn't show it so well, but these are some of the things that we actually look for. There's like ways to actually grade it based on some classic scale pictures. But there's the epicanthal folds, and you can see in this baby, you can see those pretty prominently right here. And some kids, to me, look pretty normal. These are definitely kids that we know have fetal alcohol syndrome, and I don't know that I would pick up on it on some of these, would you? Yeah, this one here. But look at the upper lip on all of them, and the no philtrum. Still don't know that you pick up on that alone. This child looks more abnormal than the others. Maybe the ears partly, and the lip doesn't look as normal. But again, you see kids that look, like this, and you wouldn't think anything of it. And then, the thin upper lip is one of the big giveaways for me. If I start to notice that, I wonder about, and I look for other features, but especially that flat mid-face. See how flat the mid-face is right there? This one doesn't have such flat mid-face. And some of these don't look so abnormal either. I don't know if I would have picked up on it on her or her. And you would think something's wrong with these other kids, but you're not sure what. But there are lots of blogs out there and web pages that these people have, support groups and things like that. So you see lots of pictures out there. I get most of this stuff from those. And some of these organizations that promote education on this. Now, I don't want to start any rumors, but this is Britney Spears back when she had her first child. I think this is her first child. She had more children than that now? You got 2 or 3? But this might be number 1. I don't know if it's number 2. And I don't know. I've never heard he's anything wrong with him, so don't start rumors. But when he was born, the first thing I thought when I saw that, all right, look at his upper lip. Look at his mid-face. Even if this angle doesn't show it so much, but he's even got the palpebral fissures things. And he's cute, but I don't know. I'm just saying. I don't know, but I would now when you start noticing children, just pay attention to some of those things, and most of the time it's fine. Mom doesn't even drink maybe. But Brittany at this time was a wild child right before this baby was born. This is when she had that terrible reputation of all the stuff, the trouble she got into. She's kind of straightened out now, hasn't she? Where are they?
The baby daddy got her.
She doesn't have her children? Oh my goodness. I should not pick on Brittany. I have no idea what her life is like. I don't know anything. I'm just saying her child looks a little bit different. Okay. So, behaviors. These are the things. These are babies that are very difficult to take care of. If they have the syndrome, they are very, very difficult to take care of. That looked like a happy little fella, so I doubt he has it. But irritability to the 100th degree, hyperactivity, very hyperactive children. Everything on them is about their nervous system being kind of malfunctioning, hyperactive, short attention span, poor short-term memory, and decreased IQ. These are some of the longer-term things. Irritability as an infant, but these other things as a child. They definitely have some IUGR, or they're usually SGA babies, because they did not grow properly. And which one of those would they be, symmetric or asymmetric, possibly? Probably symmetric if they were in the right time period for their brain not to grow, right? Persistent postnatal growth flag. In other words, they don't catch up as easily as some of the preemies and other babies might. And these are some of the symptoms of withdrawal. Usually occurs first to third day, and honestly, we don't see it much in the nursery because they go home before we start to see the real withdrawal, and we often wonder about that. If we, of course, if we know mom's drinking, now we identify drugs easier than we do alcohol, but that withdrawal is severe. If we do get to take care of those babies, usually occurs between 6 and 12 hours of age if they really were heavy drinkers through the pregnancy. And these are some of the things. You don't need to memorize them, but think about that everything is sped up, basically. Seizures, neurologically, tremors, inconsolable crying, resistant to cuddling or holding, restlessness, sleeplessness, abnormal reflexes, hyperactive rooting. So everything is to the hyperactive part of the nervous system, right? They're not those flaccid babies that are just, poor muscle tone and all that. They're the opposite. They're going to have seizures and tremors, and they're just crying all the time. They're irritable. You're going to put these babies in a quiet room to treat them. So nursing care is decreased environmental stimuli because we want to slow everything down, quiet them down, try to get control of their nervous system. Swaddle them, protect from injury during seizures, administer seizure meds, manage feeding problems because they are going to spit up everything they eat and just don't want to eat to begin with, and they're just really hard to feed. Manage feeding problems. Control body temperature, monitor vital signs, and facilitate family adaptation because, think about how much trouble they would have gaining weight if everything they do is sped up and they vomit all the time and they're, that hard to control. They're not going to be easy to get any weight on them. But family adaptation, this is you got a kid who's hard for anybody to take care of. Much less an alcoholic mother who's going back home to the temptations of drinking, and who wouldn't want to drink when their baby does nothing but scream and cry and just wants to constantly challenge everything that you do for them doesn't work. So not only does she have to now be the mother, she has to be the mother of a very, very difficult child. So this whole situation is set up for disaster. So you've got to have a lot of follow-up if you know that this is going on. That's what scares me about not seeing the withdrawal in the nursery. They go home to this, and we don't know what happens when they get home. So that's it on fetal alcohol syndrome part. So pretty much what you need is in this PowerPoint, or alluded to in the PowerPoint, at least in trying to think if there's more. Let me look in the book, make sure before I make that blanket statement. What page is it, y'all? Thank you. It didn't have a lot on just fetal alcohol, other than what I told you. Yeah, that's good. Okay, so basically the PowerPoint for this particular one, for fetal alcohol syndrome. Okay, newborn drug dependence. Of course, we know that there could be all different drugs. And we know, too, that people who use drugs, so if they come in positive for drugs or any drug alcoholic, y'all, I mean, drug user, as you know more than I do probably from what you've learned in psych, that people are usually multi-drug users. You know that, right? I learned this the hard way from my brother. I've got a brother who's been a cocaine addict for 40 years, and he's still a cocaine addict. He makes the conscious decision now that he just can't live without it, and that's just the way he's going to live. He is on a shrimp boat, and now he's getting like older and has health problems and issues, so he has to slow down every now and then, just go in the hospital and get fixed and go back out. But we've been dealing, I don't mean to be flip about it, but I've been dealing with it for 40 years. So it's, you know, if you have anybody have a amen out there, you got family members, yeah, got family members with these same issues, so you get a little tired after a while. But one time I do help him every now and then. He doesn't call on me very often anymore because it becomes a problem for marriages, and early on in my marriage I learned that you have to have some boundaries. But anyway, I got a call from a hospital in Florida one time that he was in ICU and he was probably not going to live through this overdose that he had. So I get on a plane by myself, go to Florida, get in a little crazy airport, get me a little rental car in a city I've never been in, scared half to death, find this hospital and go sit with him while he's completely nuts in the ICU, completely out of control, nobody can do anything with him. And when he finally gets to the other side of that and gets to the point where he's recovered enough to get into a room and I could have a conversation with him, they had told me while he was in such bad shape that he was positive for heroin and for like Xanax and all these downer kind of drugs. And I was like, no, he just does cocaine. And they said, no, ma'am, he's positive for heroin and all this. And I'm like, I never knew he wanted any of that stuff. He always wanted to get, piped up on whatever he could get to get really high in the other direction. So when he woke up good enough for me to ask him, I said, what is the deal? Are you seriously using heroin now? And he said, well, I don't care about heroin. I just need something to help me get a soft landing. He called it a soft landing. And he said, I don't care if it's heroin, Xanax, Valium, whatever I can find, that it makes the landing softer when you're doing coke. Do y'all know that? No. I didn't know that. I mean, I just figured maybe it's common knowledge, but I don't know it. So most cocaine users are multi-drug users. He said, I couldn't care less about heroin. I just use it just to help me with that cocaine high. When I don't want to come down crashing, I want to do soft landing. I'm like, well, let's by all means get you a soft landing because we want you to be satisfied at all costs. But anyway, that's what that was all about. And I learned, that most drug users use lots of different drugs, but for different reasons. They're not addicted to all of them. They just use them in conjunction to make one of them better. So I don't know. That's about all I know about it, but that's what I know. But that's why we test for everything on mothers when they were doing do drug screens, because no telling what they're using that they're not admitting to, because they're only admitting to their one vice. So many risks to the baby, because before they're born, you still have to worry about asphyxia in utero, infection, alteration in birth weight, and low APGAR scores. All those things that are associated with that lifestyle, too, is part of that. That's what the infection part would be. Complications, respiratory distress, for sure, because of hypoxia, if they have asphyxia from some drug, congenital anomalies and growth restrictions, behavioral abnormalities, and withdrawal. And the anomalies would be, if you're taking the drug at a certain time of development, it could certainly alter that development, right? Cocaine, actually cocaine is not had the effects that a lot of people thought it was going to have on babies. They're not as sick initially, usually, as you would think that they would be. They tolerate it better than some other drugs, unless it's to a great degree. But long term, we're not sure what all it does. We're learning. But these are some of the long-term things that we really worry about. And they were first identified by some of the foster parents who said, you better really, when this first started seeing this cocaine thing started happening 40 years ago or whatever, people started noticing a different behavior in the toddlers and the young infants, in that they seem to have like a lack of empathy, a lack of social interaction skills, and this is what it's all about. Inability to express strong feelings, poor social interaction skills, inability to adapt to stimuli, easily overstimulated, difficulty sleeping, motor delays, excessive language delays, and feeding and swallowing difficulties. So some of these things we just don't always know what caused what, because many cocaine babies are also preemies. Because cocaine does what? It's going to raise your blood pressure, cause contractions, cause early labor, and early delivery. So a lot of cocaine babies are preemies, so we don't know if being a preemie is the problem or if the cocaine was the problem that caused some of this stuff. But what they did start noticing is those kids long-term do not do well with their behavioral control, poor sleep-wake state transitioning, like me, they don't transition well, more GI illnesses, respiratory illnesses, more likely to be neglected and or abused. And that part of that is because of their inability to respond to cues and to build that bonding relationship. Foster parents were the first ones who said, before you adopt this child, you really ought to think about it. Because long term, you got some problems on your hands, because this kid doesn't seem to care what other kids are doing. That could hurt another child and wouldn't feel for them, or watch another child be hurt and not seem to have much feeling about it. Normal human emotions, kind of selfish behaviors that you don't normally see at that age. Some of those kinds of things. It's very disturbing. It's like kind of like a part of their conscience didn't develop almost. I mean, I'm exaggerating. I don't know if that's the best way to say it, but it's kind of like that when you think about their behavior, because they don't respond to things the same way. So withdrawal, we definitely have to worry about that. During the pregnancy, we don't want mom to withdraw from heroin. If she's on heroin, we don't want her to come off of it. Did y'all already learn this stuff in the pregnancy stuff? Yes? You learned this part of it about the methadone and not withdrawing. You don't want her to stop using totally. At least she needs to be on methadone. Complete withdrawal during the pregnancy is not recommended. And the withdrawal can cause fetal withdrawal with higher morbidity and mortality rates. So Narcan is contraindicated if you know a mom is on any kind of drugs when she comes in. You don't want to give this baby Narcan as soon as he's born if he's depressed, right? Because you're going to put him into withdrawal. We want to, so it's contraindicated in those cases when it's a known drug use thing. Okay. I don't know what page. I don't know why I didn't put a page number. Okay, page 60. I don't know if it's, I think I used both of these pages, 608 and 609. You need to know the signs of neonatal abstinence syndrome is what it's called. That's withdrawal. That's the other name for it, is neonatal abstinence syndrome. I think on page 608 it just gives you a list of some of the symptoms, and then 609 is more like describing the scale that they use to measure these things. But they're on both of them. So let's look at the one on the first page, 608. So clinical manifestations, remember everything is going to be that sped up kind of thing. It was a little bit different than alcohol. High-pitched cry, hyper-irritability, just kind of picture all that hyper-irritability kind of thing. Exaggerated reflexes, tremors, same things we talked about before. But then we add sneezing, hiccups, and yawning. When a baby starts, a baby has to sneeze to clear their airway, but if they sneeze a lot or if they yawn constantly, that is not normal for babies to do. We don't expect babies to have the hiccups all the time or to have the yawning or the sneezing all the time. So we start to pay more attention if we see it in a baby to a more extensive degree. GI would be like the vomiting, poor weight gain, sensitive gag. Remember that, doesn't that all kind of go together to y'all? The hyperactivity, the hyper reflexes. And then it's poor feeding. I guess that one's more, doesn't sound like it's a hyper thing, but poor feeding because they just can't, they're neurologically not intact. And then autonomic symptoms, stuffy nose or sneezing again, yawning. Sweating is mentioned under that one too. That's another thing that's not normal to see in a baby. When you see a baby sweating, they're usually either super hot, we got a good reason to explain it, we got them way too wrapped up, or we got them in a warmer that's malfunctioning, but even then it takes a while for a baby to start sweating. So that's another red flag for us. And then those cutaneous signs are more about how they're fussy and moving around. They're just kind of getting their knees sore from from being so restless. They kind of break their skin down because they just can't be still. That's all that's about. So on that other one, on 609, you don't need to look at both of them. They're both the same, really. But it's just, this is just describing the scale that's used to measure these things. We had a couple of these this semester where y'all were doing the scale. I thought I had a picture of it on here. Here it is. This is the neonatal abstinence syndrome scoring chart. So they would do this every so how many hours it's ordered, usually every 2 to 4 hours, that you would do a scale. And then your orders are written so that you give some kind of sedative for the baby if the numbers are a certain amount based on this scale. So I'm going backwards now to the newborn treatment. So urine drug screen for the mama and the baby, meconium drug screenings, they can do those too. I think they take longer, or I think they said they were just more expensive to do, is why we don't do them at this hospital. Social services referral always, of course, and then blood tests for any of the any kind of STDs, because we know that just basically kind of goes with the lifestyle, not, and especially if they're using needles for their drug use. And then these are some of the drugs that we're going to give these babies: morphine, Paragard. I've never given Paragard in the nursery, but definitely given a lot of phenobarb and Valium and morphine, because these babies are, if they're really in withdrawal, they are miserable. They are really, really sad because they are just screaming and you can't console them. The things you do to console babies doesn't work. They're just, you could just tell they're just coming out of their skin. They are very, very much in pain just from the withdrawal. It's a horrible thing to watch. And some of them you really can't put your finger on it, what's going on with them. They're just really hard to satisfy, but not to the degree that you're thinking they need drugs for it. Nursing care, scoring them, vital signs, monitoring their sleep patterns. You want to get a lot of calories in them because they're using up calories fast, aren't they? If they're going to be that hyper and everything, they're going to be using up their calories pretty fast. Put them in right side to help with their feedings, suction if you have to, monitor the vomiting. So all this is about the symptoms. Swaddling, but not rocking and moving. They need to be swaddled and held still and allowed to kind of collect themselves. Well, it says gentle rocking. So you do want to give them some containment, I guess, is why the swaddling and the holding. Protect their skin, protect their diaper because they have all this diarrhea. Quiet, dimly lit area of the nursery. They're usually in a separate room, so they're not hearing all the other babies, they're not hearing people. And medications for withdrawal. We had a lot of these last year. We had quite a few we had in isolation. I don't know, we've only had a couple this year, and none of them were like severe where we had to really put them in isolation or anything. But we have that, that little room across in the nursery that has a separate sink. That's like an isolation room with a glass in front of it. So we can put babies in there, and then the nurse would go in there to feed them, and the doctor would see them in that room. They're not brought out among all the lights and all the noise and everything. And of course, taking them home is a big problem because we don't know what kind of home they're going home to. But if they do get taken away from the mother, then, most often they go home with a family member. So that's not always, that's usually the mother still, but just lives with the family member. So sometimes they can request, social service can require that they not have any contact with the mother, and they're supposed to do follow-up visits and all of that. Just so much involved in that. Y'all know my son, most of you know that he had a 3-year-old foster child, and his mother just got custody last Tuesday. After they've had him for about a year, he's 3. Broke their hearts, but his mother was her story. It was the drugs, and he's a child who's handicapped, needs therapy, and she wasn't taking him to therapy appointments, and so he just got more and more delayed, and he couldn't walk at all when he came to them. He can stand now, and they've done a lot with him, but he's got a syndrome of some sort, so he's never going to be without the need for all of those extra services. And she doesn't get him to them, but she got custody back. And, they're just really scared about it because she lied about where she was and all kind of stuff. And the social services, y'all, is really it's really sad. They don't have nearly enough people to do what they do. They all mean well, but they're just not enough of those social service people to do it. I mean, he would have somebody different in court than he had that had known anything about him. Some other person would show up in court to testify and had never even met the child, and would same with the mother, would say that the mother had a job and that she had an apartment, and she had already lost her job, but the judge doesn't get to hear all of that. It's just so frustrating. But this is what I don't even know why she wants her children. She has 2 handicapped children and 2 others, so she got all 4. Well, she got 3 of them back the other day. The oldest one, the grandmother has. That one has cerebral palsy, and the grandmother has that one. But she's got all of this. I hope she's got her act together, because now she's got 3 boys that are going to live in the living room. There's no room in the house other than in the living room with the television. Well, Marcus is used to his own room. He's used to quiet at a certain hour. He gets his supper, he goes to bed, he's in the quiet, and he sleeps till a certain hour, and he gets up. Well, now he's just got chaos. I mean, it's just the way they're going to live. So I hope she's got her act together, because when they don't, they drive the mama crazy. Because that was the first thing that my son's wife said. She said, if he doesn't get his sleep, he's a bear to deal with. He is so grouchy. And now he'll be sleeping with the same room where the TV is and the other kids are. So he'll wake up grouchy. He'll be grouchy all day, and then she will get mad at him. And that's her fear, that he will not be taken care of. So this is what these people do. Even a normal, supportive home, it's hard to deal with kids like this. But if you don't have any support, or you don't have the resources because your first act is to reach for something to relieve your stress, how are you going to deal with it? It's really sad. Let's see. And the symptoms last a good long time, too. These kids need support for a long time. This is physical withdrawal. They are sick. They are very sick. They usually have cardiac apnea monitoring. Mom needs to learn infant cues. Oh, goodness, help with that. And resources and long-term follow-up for sure. Okay, so it's a sad thing. Our state, by the way, just so I'll throw this in there since it is kind of unique to South Carolina, is that our state's kind of famous for being the state that locks up, or used to lock up, pregnant women when they were positive for drugs. So if y'all ever hear that, it's true. When I was in the NICU, it was still legal at that point that if a mother was positive for drugs during her pregnancy, she had a choice. She could either go for treatment or go to jail. Those were her choices. And that was, in part, the response to some research that a doctor and a midwife did at MUSC. And they kind of showed all this concern about these mothers who were doing drugs during the pregnancy and harming these babies. So they did it for a good reason. They were really concerned. But what do you think the effect of that is if you put women in jail when they're pregnant and they're positive? They do what? they don't get their prenatal care. Because if you think you're going to get locked up, you just don't come, right? Because especially if you don't plan to quit using the drugs, or you don't think you can stop using the drugs, you just don't go for prenatal care, and therefore baby's even worse off. So, and plus our jails are not set up for pregnant people. It would just mix them in with everybody else. So then they had to, get special arrangements to get them transported to their doctor, to their appointments, and it's not set up for helping a pregnant woman. So until they are set up that way, it doesn't seem like the right thing to do. So anyway, South Carolina got all over the news for doing that. And one of the things was the women who were in the study sued NUSC because they were not told they were in a study. They were just pregnant women who got tested. And that's a problem, right? We know that research studies, you have to agree. So the women sued for it. And the other thing is they were only doing it in USC, where there were more indigent patients. All these private places weren't testing for drugs. So all these people with money weren't getting tested and weren't being put in jail. And we know they might have been doing even more drugs because they had the money to do it with. So it wasn't fair, and it caused a lot of problems. NUSC had to change their policy, and the solicitor at the time was part of that study, the solicitor for the Charleston County. So he was part of it, and is Condon. He's still around. What's he doing now? I don't know what Charles Condon does now. Y'all don't know, but anyway, he was part of it. He was very hard on drug users. But at any rate, South Carolina kind of got in the news for all the wrong reasons, but they meant well. They thought they were going to try to fix this problem, because if you're in the NICU and you see the same mama keep bringing you babies, I mean, I was there when we still had one of her babies, and she brought us another premature baby. And we would watch that baby be tortured and, so miserable, still on a ventilator, still so sick, and she's already had time to go and get pregnant again and bring us another one. It is very, very hard to work with kids like that and not feel like you want to do something about this drug use with pregnancy. And it's very, very sad. I don't know what the answers are, because goodness knows we apparently haven't found the answers. But I do know that it's hard to not have some resentment about it when you're the person taking care of these babies and you watch them being suctioned and, getting IVs and PICC lines and surgeries and all that. But at the same time, I had to learn the hard way, because you feel that way until you meet the mother. And when that mother comes in and she's crying and she's so remorseful, she's horrified that she did this to her baby, and then she goes out and does it again. And some don't, but most do. And most of them, I learned, at least at that time, we saw some of the worst cases, obviously, but they were prostitutes because they needed the drugs. So they would have the baby, and they wouldn't even stay for their discharge. They would escape and get out of there before it was time, because they needed the drugs by then. So they'd leave and start prostituting themselves very soon, and that's how they had us another baby in 6 months. We'd have a 6-month gestation baby, so they didn't even wait long because they need the drugs. They're really addicts. So it's a terrible cycle. And at that time, you had to be 21 to get your tubes tied, even if you wanted them tied, even if you had 3 or 4 kids. You had to be 21. And these women weren't 21 yet, most of them. I don't know what the law is now. Do y'all know? I mean, for Medicaid, these were usually... Holly. Really? Mm-hmm. Yeah, but it depends. Right. Yeah. Had to be married.
Yeah.
I can see if they could suggest that to you, but I don't know how they can make that decision for you. Certainly they could advise you.
There was a doctor in North Carolina that was
He was what?
He was tying their tubes
What?
because they were multiple babies.
Oh my gosh.
And one girl tied the pregnant.
Ah. Oh my goodness. He was controlling the population all by himself. You might consider that a little bit of playing God there. Gosh, no consent form or anything, right? Wow, that's extreme. That really is extreme. It's a really tough issue. I mean, I've seen some mothers come in there that I really, really liked them. When I knew them, I just bonded with them, and I thought, this person's never going to do drugs again. She's just so committed, and I mean, they're just so remorseful, and they feel awful, and they're just crying the whole time, apologizing to their baby, and and I guess some of them probably did change their lives, but it's hard. It's really hard. And then you take that baby home that's also hard to take care of while you're trying to now come clean. I don't know. So bad. It's just such a hard situation. Okay, the only thing you're going to need to know about HIV and AIDS is just a couple of little things, because y'all know more about this than I do. But I just know a little bit about it as far as babies go, and I want you to know how it affects the babies in terms of when we're going to test. I think in PEDS you would have learned about taking care of babies with HIV and protecting in the home and all that. But you're always going to test moms during pregnancy. That's mandatory testing for HIV now. And we know that it can be transmitted through the placenta, during the birth process, or through the breast milk. So they never breastfeed. And also, drug positive moms can't breastfeed either. If the mom is not treated with antiretroviral drugs during pregnancy, the risk of vertical transmission to baby is 15 to 35%. I think your book gave some different stats this year, but it might have been on the other part that I was thinking about, though. It might be this next statistic. Can't remember which one I read. No, it might be this. Anyway, down here, this next one is one that really... 25 to what? I thought it gave a whole different number. I'm not going to ask you that anyway, but the point is the drastic difference there is here. The risk of transmission is reduced to 1 to 5%, and this says 1 to 2% with preventive treatment of mom and baby. Y'all, that's amazing. That is just amazing. Before that happened, we didn't have a lot of hope for these kids. We just didn't know what was going to happen to them. This was just the most amazing thing when it happened. I remember it, that we actually found something that worked, and it kept these babies from having a death sentence, basically, at birth. That we are reducing the chance by that much. So that means that we treated the mom during the pregnancy and the baby as soon as they're born. The diagnostic test, the preferred test is the DNA PCR test. The book name's another one, but this is the one that I want you to know. This is from Dr. Kilgore, and also your book does endorse it, but Dr. Kilgore said this is the standard of care. So they're tested at birth, never on the cord blood, because you wouldn't know if you're getting the mama or the baby's blood, right? So we don't do the cord blood. And then every 1 to 2 months, and then again at 4 to 6 months. And then the infant is considered uninfected with HIV when HIV-1 antibody assay is negative at 12 to 18 months. Now they can be positive sooner, but if you want, and you could tell somebody they're sick and they do have HIV sooner, but to tell them they definitely don't have it, it's going to take that long, because we don't know if we're testing some of the effects of the mother still. So, and they would have no findings, no physical findings consistent with HIV. So all their testing is negative at 12 to 18 months, and they'll say your baby does not have HIV. But you can tell them sooner that they do have it because they're sick. They've got all the signs. They've got the pneumonia and whatever else, okay? So prophylactic AZT, administer orally at 8 to 12 hours of life and continued for the first 6 weeks. We've given that quite a few times in our nursery here. Okay, any questions about HIV? That's all I need you to know. Okay? I just want you to know how we test and how we that it is possible to transfer it, and that the chances are very, very decreased, and that we don't breastfeed. Okay. Then newborn screening. Oh, what time is it? I got to look at my clock. Okay. So, I'm trying to think where I'm going after this, because we got to go over the anomalies too. Oh, yeah, we're going to need to take another break then, because I still got to go over the anomalies too. There's just a few, but we're going to finish this chapter today. Y'all want a 10-minute break? Oh, it's till 11. I was thinking 11:30. Dang it. Oh, man. Okay, so let's do this then. Keep going. All right. So you know what I mean by newborn screening is this, right? This test that we did with the drops of blood. This is called the Guthrie blood test. So now I'm going backwards. Detects inborn errors of metabolism, all kinds, hereditary disorders that lead to toxic buildup of metabolites, and not all of the tests are done on metabolic disorders, but they're hereditary kinds of disorders. Many of them, if you don't treat them, they're going to lead to intellectual issues, but if you do treat them, you can prevent those issues. So that's why it's so important to treat everybody, even though they're pretty rare. Most are treatable, and early intervention is essential. They're going to be different in every state. Our state tests for a lot, and I think every state has to test for certain ones. That's the PKU and congenital hypothyroidism, but there are lots more that every state tests for, but they're not all exactly the same. The cystic fibrosis and sickle cell anemia is worth mentioning too, because sickle cell anemia, in this case, of course, it's not a metabolic disorder, but just like to tell parents that it's going to test for the trait, but they're probably not going to notify you unless your child has the disease. So if you want to know if your child has the trait, then you need to just ask your pediatrician, because they have those results, but they just don't let everybody know necessarily that they have a trait. But I think most people would want to know that about their child. Maybe not. And then congenital adrenal hyperplasia is the ambiguous genitalia one. You knew that? That's the one where you can't tell if it's a boy or girl without testing. So that one's a good one to have on the list as well. So I want you to know how we collect this and when do we collect it and all that. And since most of it is about metabolic disorders, you need to metabolize some food before you give the test. So they need at least 24 to 72 hours of feedings before you do the test. Now, it's state law, we have to do it before they leave the hospital. So even if they didn't get enough feedings, we still have to do it and then ask them to come back for a follow-up and hope that they do. There's a filter paper that's used. You have to collect the drops in a certain way. It can be really aggravating, but I think I said if they get discharged early, they still have to have the test, but it has to be repeated. Some states repeat everybody's. They have to come back and repeat it because they think it's more accurate if they've had 3 or 4 or 5 days of feedings. But we don't require them to come back. That's what it looks. Filling up the little circles has got to be perfect, or else it gets sent back. So always tell parents, if you get a letter that says you need to have this test repeated, listen to what the letter says. Don't panic and think my child has some terrible disease, because most of the time it's because they need the test repeated. The circles weren't filled in correctly or whatever. It's a very finicky test. But then if they choose not to come back, they don't listen to the letter, then there's nobody that goes out and gets them and chases them down. So we need to explain to them how important that letter is when they get it. As far as your anomalies, let me just tell you which ones you're going to be looking at. And we will try to go over some of them later, but I think they're really review for you anyway. Choanal atresia, remember that's the one that pinker when they cry. That's on page 598. TE fistula or tracheoesophageal fistula is on 599. This should be a review for you. I'm not going to go over cleft lip or cleft palate or ask you anything about them because I think you covered those. TE fistula you've probably covered too, but this one this is the reason we give the sterile water first, because this would definitely cause them to aspirate, possibly depending on where the fistula was. Page 600, the diaphragmatic hernia. That's one member is associated with a barrel-shaped chest, scaphoid abdomen, right? Yes? Yes. Okay. So, because intestines are above the diaphragm. On the same page, phalloceal. That one's when the herniation of abdominal contents into the base of the umbilical cord. We saw lots of those in the NICU. Really great outcomes when they have their surgeries, though. These babies are very normal when they get their treatment. There's certain kinds of surgeries they can do. Gastroschisis is on 601. And then prune baby syndrome, I just wanted to point that. I'm not going to ask you about that one. That's pretty rare. But absence of one or more layers of abdominal muscles. So their bowels are fine in there, but the musculature is the issue. It's a real big problem. Okay, 602, myelomeningocele and imperforate anus. And I don't want you to know everything about them, just know kind of the definitions. And, well, definitely for diaphragmatic hernia, it was the symptoms, and for choanal and TE fistula. But not all those other ones. I'm not going to get into all the specifics about those. Any questions, y'all? We did it. The whole chapter. That's a long chapter. That one covers a lot. Can you imagine doing that plus what you already had test on? That in the next chapter too? Okay. Did I never start this one, y'all? Hadn't been like that the whole time, has it? It hadn't looked like that. I did have it up, didn't I? I had it up like that. Thank you. Whew.